Hi there. Today I will be talking about shoulder pain examination. The clinical examination starts with the patient their shirt off, because here I can assess the limitation of range of movement, or any functional abnormalities. I will start with a general inspection of the front, the side and the back. Here, I will look at the muscle bulk or any bony abnormalities. Before conducting the examination, it's best practice to do an examination of the cervical spine to ensure that no pathology is involved here and it's purely shoulder. We assess the range of movement by forward flexion, abduction, crossbody abduction, external rotation, extension, and then turn around for the internal rotation. It's good practice to get the patient to repeat the full range of motion whilst you observe the scapula. You look for any asymmetries and scapular motion. Next, I am going to show you targeted clinical examination of the shoulder joint for the most common pathologies. I will start with rotator cuff pathology as it is the most common diagnosis. There are 4 rotator cuff tendons: Supraspinatus, Infraspinatus, Teres minor, Subscapularis. Supraspinatus is the main muscle for abduction during the elevation. Infraspinatus and Teres minor are responsible for external rotation. Subscapularis is responsible for internal rotation. To test the supraspinatus, have the patient in 90 degrees of abduction and 30 degrees of forward flexion. Here, I test for the power of supraspinatus by pushing down. I also make sure the left side is equal to the right, and there is no pain involved. Then, I get the patient to simulate emptying a can by bringing their thumb to the floor, and I can assess the power again, and ask for pain. I can assess the integrity of infraspinatus and Teres minor by resisting the external rotation. I look for any pain and loss of power or any asymmetry. This test is for subscapularis. Have the patient in this position, and if the patient can maintain the position, that is normal. If there is an internal rotation lag sign, then the patient's hand will drop towards the back. I can also assess this test by Gerber's lift-off test, where I ask the patient to resist my downward motion. Serratus interior weakness is identified by asking the patient in a standing push-up position. You see the motion of the scapula. If there is scapular winging is involved, it shows the serratus interior weakness. Rotator cuff pathology in younger patients is usually associated with trauma, while in the older patient, it is usually associated with a gradual onset of pain. The next pathology is shoulder impingement. There are 3 special tests for impingement. The first one is Neer's test. I ask the patient to fully internally rotate the arm and passively flex the shoulder joint. If the patient experiences pain over the anterior or lateral deltoid, the test is considered positive. The second test is called the empty cane test. The patient's arm is abducted to 90 degrees and forwarded to 30 degrees while the thumb is pointing downwards. Stabilize the shoulder, apply downward pressure on the wrist, and ask the patient to resist. If this elicits pain, then it is a sign of impingement. The last test is Hawkins-Kennedy Test. To perform this test, stabilize the shoulder with one hand and bring the patient's arm forward, so that there are 90 degrees of angle between the elbow and the shoulder. Now, internally rotate the shoulder with forward adduction. This test is positive if the patient feels the pain. Patients with shoulder impingements can also have asymmetries in their scapular motion. Speeds and Yergason are 2 special tests for biceps tendinopathy. Speeds test is performed with the patient's arm at 90 degrees of angle while the palm points upward. Apply pressure on the patient's wrist and ask the patient to resist. If the patient feels the pain, then this test is positive. In Yergason's test, the patient is asked to resist the supination. To perform this test, ask the patient to reflex the elbow to 90 degrees and pronate the forearm. Grab the patient's wrist and ask them to supinate their forearm while you palpate the origin and insertion of bicep tendinopathy. Adhesive capsulitis is usually shown by the reduction of the range of movements, both actively and passively. External rotation is the first range of movement to be affected. With adhesive capsulitis, you often see an asymmetry in scapular motion secondary to the limitation of the range of movement in the glenohumeral joint. It is useful to know that many patients have muscle spasms and trigger points within the trapezius. In the initial stages of adhesive capsulitis, there is a painful range of movement. Later on, there is a restricted range of movement. The acromioclavicular joint disease causes localized pain over AC joint. Patients can also complain about night pain. To assess this, locate the AC joint and feel for a step-off deformity. Ask the patient for a pain. Scarf or crossbody adduction test is used to assess the AC joint. To perform this test, support the shoulder of the patient and lift it to 90 degrees. Horizontally adducted the shoulder as far as possible. This will produce a force on the AC joint, and if the patient feels pain, then the test is considered positive. There will also be a painful arc in the 150 to 180 degrees of abduction. Shoulder instability can be assessed by the sulcus sign. Here I apply the downward force of the humerus and I look for a sulcus sign that will appear on the lateral side of the deltoid region. Another way to test shoulder instability is the apprehension and relocation test. To perform this test, have the patient in this position with their arm abducted to 90 degrees and elbow reflexed to 90 degrees. Place one hand under the posterior aspect of the shoulder and scapula to stabilize the position. Now, push the wrist posteriorly to induce external rotation. If this causes pain, instability of the shoulder is involved. Now for the relocation test, place the hand from behind the shoulder and push the humerus posteriorly. If the feeling of anterior displacement of the humerus is relieved, this confirms the positive test and indicates the shoulder instability. Laberal tears or slap lesions are commonly seen in athletes and accidents. The first test for slap lesion is the speed test, where speed is resisted forward flexion and I ask the patient for a pain. In Obrien's test, I ask the patient to resist the force I am applying downward. If it causes pain, then this test is considered positive. The final one is the crank test, where I internally and externally rotate the shoulder. I ask the patient for any pain, and I palpate for clunks.